In this chapter, we're going to deal with probably the most popular window in echocardiography, the apical window. Well, in the basics of imaging, I told you that the point where you image the apical window might vary from patient to patient. But in principle, there's a simple way to find the apical window. Let's take a look. So, where is the apex of the heart? Well, that depends very much on the habitus of the patient. If, as in our case, the patient is very slim, the apex will be much further towards the midline, as, for example, in obese patients or in patients who have a diaphragma which is very far cranial. In such situations, you might have the apex even almost on the back. So you will have to experiment a little bit. But one thing that you should try, especially at the beginning, is try to palpate the apex. In his case, you can actually see the apex moving, and if I put my finger here, you can see the motion very clearly. This is where I would put the transducer. But before I do so, I always put the patient in a more lateral position, not as far as I would if I image the peristernal window. And then I would place the transducer here on the apex and then adapt my image to adjust the septum, which should be in the midline and more or less parallel to the ultrasound beam. The other thing that I try to do is I try to test whether or not I can move one intercostal space further down, because here I would have what we call foreshortening. Let me show you what happens if I move the transducer down a little bit. You see the apex now is a little bit more pointed and the whole ventricle is longer. So this would probably be the ideal position to image a classic four-chamber view. So when we image from an apical position, the apex is going to be the structure you're going to see on the top of the screen. But the part of the ventricle or the heart that you will image depends greatly on how you orient your transducer and also how the image plane goes through the heart. So you will have a number of different image planes from the apical view. And here they are. We will have the four-chamber view, the three-chamber view, and the two-chamber view. These are views that you acquire by rotating the transducer. Then you will have the four-chamber view and the five-chamber view, where you are staying at the apex, of course, and just tilting that transducer up or down. And then finally, there's another special view that I will teach you, the so-called coronary sinus view. I'll talk later about what the intention of this view is and where it will really help you. But now let's take a look at the four-chamber view, the most popular view in echocardiography. We already talked about the apical window and how we can find it. Now we'll show you how to optimize the four-chamber view and how you can acquire variants of this view to demonstrate all the different segments that you need to see. So when we place the transducer on the apex, you will have the index finger here on the marker, where the marker is pointing lateral and the transducer is pointing towards the right shoulder. You will be imaging upwards, where you have to tilt the transducer so that you really cut through the ventricles. So now I'm placed in the transducer here in the apical region, and I get a very nice four-chamber view where the septum again is parallel, and you can see a very long left ventricle which has the shape of a bullet. What do I see in this view? The septum, the apex, and the lateral wall. You see the anterior leaflet and the posterior leaflet of the mitral valve, the left atrium, the interatrial septum with the fossa ovalis and the septum secundum, which is a thicker part here. This is the tricuspid valve, and the right ventricle here with the moderator band. Now, I would not stay with this view if you image a patient, but use certain variations. How do you do this? Well, you do this by encircling the apex. Now, first I will move more medially, and what happens now is that the septum will move in a slanted direction towards the right of the image. This view is ideal if you want to really image the lateral portions of the left ventricle. Maybe not so good in this patient, but usually you will get a much better view of the lateral segments. Now, if you go back to the four-chamber view and then move the transducer the other direction, more laterally, you'll get a fantastic view here of the right ventricle, where it is possible to nicely assess right ventricular function and where it is also possible to nicely measure the thickness of the septum. So remember, don't stay in a fixed position with the 4-chamber view, but always move from lateral to medial to encircle the ventricle. If you judge the quality of a good 4-chamber view, base your judgment on whether or not you're really seeing 4 chambers, if all these chambers are seen in their maximal dimensions, if the ventricle has a bullet shape, if the wall of the left ventricle is thicker than that of the right ventricle, and obviously you should be able to see the mitral and the tricuspid valve. Now we'll take a look at some variations of the 4-chamber view and how you can improve the information that you get from a 4-chamber view. Watch the simulation. Let's take a closer look at the 4-chamber view and its different variations. Now, if I tilt the transducer a little bit more caudal, you will see the coronary sinus right here. This longitudinal structure is at the base of the heart and enters the right atrium. It's the coronary sinus. Vice versa, if you tilt the transducer, you will get to the aortic valve. This is the classic 5-chamber view. But remember that with a little bit tilting of the transducer, you can even see the pulmonary veins. This is the right upper pulmonary vein, which is very important if you want to assess Doppler flow into the left atrium. But you can also see the left upper and sometimes also the left lower pulmonary vein, which is close to the left atrial appendage, which can be seen sometimes, especially if it's large, in some patients right here at the junction between the left ventricle and the left atrium. It's also important to note that you can get certain variations of the 4-chamber view if you want to focus on certain structures. For example, if I want to see the right ventricle, I would move the transducer a little bit more lateral, then I'm more perpendicular to the right ventricular wall, which can be seen very nicely here. Vice versa, if I move the transducer more to the medial, to the sternum, I will have the septum slanted in such a direction that you have a very good appreciation of the lateral wall right here. So keep this in mind when you image. Don't stay fixed to the classic 4-chamber view, but move around a little bit and you will see more structures and get much more information. So remember when you image to encircle the heart and look at different portions of the ventricle. In addition, don't forget that we see more structures actually. For example, the pulmonic veins, the right and the left pulmonic veins, which are here. And then finally, that we also need to image the base of the heart. These structures here are equally important, especially the coronary sinus, which you can see right here. As a short review, let's see what happens to the septum if you encircle the left ventricle. Let's also talk about when you should use which view and where it is helpful. So if you move the transducer more medial, you'll have a position of the septum where it is pointing to the right of the screen. You will use this view to image, for example, the thickness of the septum very nicely. You can look at the intraatrial septum and detect an atrial septal defect. And it's ideal to also look at wall motion abnormalities in the lateral wall. If you move the transducer more towards the lateral position, you will get an orientation of the septum here towards the left. In this situation, you'll have a beautiful view of the right ventricular free wall, which is right here. You'll have a very good view of the right ventricular apex. And you'll also have a very good view sometimes to detect an atrial septal defect here as well. So these are the variations of the 4-chamber view. And here is again a review slide that shows you all the 4 different positions. The normal 4-chamber view in the middle. On the right-hand side here, the lateral position, and here would be the medial position. Now the images that go along with these orientations, beautiful appreciation of the lateral wall here. Here the septum in a normal parallel position, and here the septum is slanted to the left. If you image from lateral, look how nicely you can now appreciate right ventricular function here in this slanted view. In the next demonstration, I want to show you how you can image structures, for example, such as the pulmonic veins. But before I do so, let me display on the model where they actually are and which structures are close to them. This is the left atrium, and here you have an upper and a lower left pulmonic vein. Notice that the left atrial appendage, which is this blue structure here, is very close, especially to the left upper pulmonic vein. And also note that between the left atrial appendage and actually the upper left pulmonic vein, there is a ridge, a so-called limbus, which you can, I think, very nicely appreciate right in here. This is the limbus. Okay, now if you turn to the right pulmonic veins, they are, of course, entering the right atrium from the right, and they're pretty close actually to the descending aorta. So keep this in mind when you image, and it will be easy for you to differentiate where the pulmonic veins are. Now, it might not always be so easy to see them with transthoracic echo, but in many situations, especially if you know where they are, you can actually find them. So here is the demonstration. Can you see the pulmonic veins? Yes, you can, especially if the image quality is good. It's very simple to identify the right upper pulmonic vein. It is located close to the intra-atrial septum, and if you tilt back and forth a little bit, you will see it enter right here. It is often helpful to use color Doppler while you optimize the PRF to a lower flow velocity. So here is the right upper pulmonic vein as it enters the left atrium. You can also see the left upper pulmonic vein. In this case, it's very difficult to see, but it should enter somewhere here. And the left lower pulmonic vein, right here. The right upper pulmonic vein is probably the best vein that you can investigate with Doppler because you have a flow direction which is pretty much parallel to the direction of blood flow and to the direction of the ultrasound. Note that you can also see the left atrial appendage. If you rotate the probe a little bit more towards a two-chamber view, you will get the left atrial appendage right here as it overlaps more or less the left ventricle. So these are the structures that you can see in addition to the structures that we've talked about before. So in summary, it's quite easy to actually see the pulmonic veins, especially the left pulmonic veins and the right upper pulmonic vein. Keep in mind that the intra-atrial septum is quite close to the right pulmonic veins and the left atrial appendage is close to the left pulmonic veins. Good. Now we'll talk about a specific problem that is frequently encountered. It's the problem of foreshortening. Here is a demo to show you what it actually is. So what is wrong with this ventricle? I guess you can tell by now. It's too short. We have foreshortening. Let me demonstrate this. I will freeze the image and measure the distance, and you will see it's only 6.3 centimeters. Now I will move the transducer down one intercostal space, and all of a sudden it will get much longer, and the apex will also be more pointed. And if I measure the apex now, you see that its length is almost 8 centimeters. So you see there's a big difference. The difference between this is the amount of myocardium that you're not visualizing when you have foreshortening. So how do you prevent it? Well, you prevent it by always testing if you can go one intercostal space further down or not. Now, in reality, if you want to image the mitral valve, you don't have to care about foreshortening. This is only important if you want to look at the apical segments. So I would always use both, sometimes even a foreshortened ventricle, because in a foreshortened position you often have a better image quality, especially the basal portions of the heart. Here's a schematic that again demonstrates foreshortening. In reality, you should be imaging from the true apex, but in foreshortening you're not. You're imaging from a much more cranial position, right here. Now, if you look at two images, the one on the top here is the one which is foreshortened, and this is the correct image. In reality, it almost looks like a different patient. Look at the length of the left ventricle here, opposed to here. This is definitely a problem because you will miss a lot of pathologies which might be present in the apex. Sometimes you even see extreme forms of foreshortening, and sometimes this is the only thing you can get. Still, try to avoid foreshortening and try to be as far at the apex as possible. Here are some of the implications if you're not. Usually if you have foreshortening, you will calculate lower volumes. You will miss a pathology, for example, such as this apical thrombus right here. You will miss a supraapical infarct, especially if they're small. To avoid it, try to move the transducer caudal as possible and also more lateral, because there you will orient your probe a little bit more towards the apex and you will see the full length of the apex. Maybe the image might not be nice, but you will still be able to see a pathology such as this thrombus right here. In addition, if you use a two-chamber view, you will always see more of the apex because, remember, when you use a four-chamber view and if you have foreshortening but then move into a two-chamber view, you will definitely see more of the apex. Why would you use the four-chamber view? Well, the question would actually be much better if you say, when would you not use the four-chamber view? Because it's so good for so many things. For example, you can look at the left ventricular function, the size of the ventricle. You can look at right ventricular function. Note that the function of the right ventricle is impaired here. The size of the atria, the position of the interatrial septum, function of the mitral valve, whether or not a pericardial effusion is present, and so forth and so on. Of course, if you add other modalities such as color Doppler, you'll even be able to assess the degree of mitral regurgitation and many, many, many more things. So ultimately, the four-chamber view is probably the most important view in echocardiography. And if I were to go to Ireland and I could only take one view with me, I would definitely take the four-chamber view with me. From a four-chamber view, by simply tilting the transducer, you can get two very important additional views. The first view I'll show you is the so-called five-chamber view. Here we are tilting the transducer more cranial. The five-chamber view, a very simple view to get. All you need to do is simply tilt the transducer more ventral. Let me show you how I do this. I make a motion like this, and all of a sudden I will have the so-called fifth chamber, in this case it's the LVOT, in the middle portion of the image. This would be the aortic valve. Now note that you're losing parts of the atria, especially the left atrium, and you're not going to image the same segments in the left ventricle as you would in a classic four-chamber view. Now this could also be an advantage because now you will see the more cranial portions of the lateral wall and more the anterior septum. If you really want to perform the five-chamber view to assess, for example, the flow in the LVOT, I, however, would advise you to use a special modification of this view. How do you get that? Well, remember what we said about the four-chamber view? You can actually rotate around the apex. And I would do the same thing now in a five-chamber view. I would move the transducer a little bit more lateral. What happens? Well, you have a much better orientation of the Doppler signal now towards the LVOT and the aortic valve. So this is actually the view that I would prefer if I would be looking for aortic stenosis. So in summary, with the five-chamber view, you'll be able to visualize the left ventricular outflow tract, the anterior part of the septum, and also the right ventricle, of course. The atria sometimes might not be displayed in their full extension because you'll be cutting more or less on the roof of the atrium. Here's a typical five-chamber view again. You can see the aortic valve right here. This is the fifth chamber, the left ventricle, the left atrium, right atrium, and here is the right ventricle. Look at the valves here. In this situation, you will not be able to discern between the anterior and the posterior leaflet. You're kind of cutting almost through the ring already, to the anterior ring. And the same holds true also for the tricuspid valve. So the five-chamber view, of course, gives you a different part of the valves, but it is not the ideal view to get an overall impression of the opening and closing motion of the valves. As with the four-chamber view, you can modify the view a little bit. For example, you can use an orientation where the septum is either more parallel or, as in this case, oriented more to the left. This is the view that I would prefer, as already mentioned in the demonstration, to assess the flow across the aortic valve or the LVOT. In summary, what is it good for? Looking at the aortic valve, aortic stenosis, looking at the LVOT and its problems, membranes, obstruction, looking at the anterior septum if you want to look at regional wall motion abnormalities, and basically also to look at certain portions of the mitral valve. Now we'll turn to the second position that you can obtain from a 4-chamber view. In this case, we'll be tilting the transducer not cranial but caudally. This is the view that we call the coronary sinus view. Let's take a look at how this is acquired. I guess you probably know by now that I am a fan of standard views, but only if you use them as anchor points. It's equally important to image between these standard views. Let me show you how you can sweep through the left ventricle to display all the different portions of the ventricle and of the valves. Here is the 4-chamber view, and now I will tilt more caudally, and the further down I go, the less I will see of the mitral valve, and I will also get a structure into my field of view which enters the right atrium. This is the coronary sinus. Now if you image in such a view where you're transversing the ventricle right at its base, you will also cut the IVC in a more orthogonal way. So this is not a pathology, this is just the IVC. Remember that you're also imaging different portions of the mitral valve. Here you have more the posteromedial portion of the mitral valve and also different portions of the myocardium. So this would be the real inferior part of the interventricular septum. So where do I use this view? First of all, to look at wall motion abnormalities in these regions and also display the coronary sinus and more the posteromedial aspects of the mitral valve. So in summary, what do you see in the coronary sinus view? You can see the coronary sinus, of course. You will see the basal portions of the mitral valve and also of the tricuspid valve. And you will see the basal inferior septum. And that kind of also explains which pathologies you would be looking for here. For example, vena cava sinister persistence, or maybe an infarct, an inferior infarct that often manifests itself here in the basal inferior septum. Now, the coronary sinus view is not a really classic standard view. It's kind of a little bit of a hidden view. But there's another view that I would like to teach you, which is also not a standard view, but if you know that view, you are a true expert of echocardiography. It's a view where you can actually visualize the pulmonary artery from an apical approach simply by over-tilting towards the 5-chamber view. Here's how this works. Did you ever wonder what happens if you tilt the transducer even further ventral from a 5-chamber view? Well, let me show you. Here we've got a 5-chamber view, and now I'm tilting more ventral, and all of a sudden you have a new structure in your field of view. What could this be? Well, it's the pulmonic artery and the pulmonic valve. You can actually place a pulse wave Doppler in this region and get a rather nice signal. Where can you use this? Well, you can use it in situations where you cannot otherwise image the pulmonic valve. And it's usually easier to find if you use a foreshortened 4 or 5-chamber view. Before we go on, I want to show you again the coronary sinus and also lead you to some important facts. First of all, the coronary sinus is at the base of the heart, and it lies in the groove between the atria and the ventricle. It has a conical shape, and usually it is not more than maybe a centimeter or so large. If it is enlarged, then there is a suspicion that the patient has vena cava sinister persistence. Now, this is such an example, and this also shows you a coronary sinus view and explains why this view, at least in some pathologies, is important. In addition, it allows us, for example, to look at wires which are in the coronary sinus in CRT therapy, and also to see whether or not pulmonary pressure is high, or at least right atrial pressure is high, because there you will also see a dilatation of the coronary sinus. So this is a beautiful example of where this view might be important. Of course, as already mentioned, you will be able to see different parts of the mitral valve. You'll see the posteromedial vicinity of the mitral valve, and you'll be able to observe the wall motion of the inferior septum there as well. We now completed all the views that you can acquire if you tilt the transducer, but we still have to learn what you can see if you rotate the transducer from the same position, from the apical position.